Good morning, everyone. It is 10 o'clock and it is time for our every 2-week coronavirus virtual information session on a Tuesday at 10 o'clock, presented by the Traeger Institute. We are really excited today to welcome our speaker, Dr. Ruth Carrico. You just give me a minute. I am going, I don't know what happened now. Suddenly my email is missing. There you go. She's going to talk to us about flu and COVID-19, the seasonal diseases during a pandemic. We're really happy. She talked to us way at the beginning of COVID-19 about all the challenges they were facing at that time. So I'm really excited to have her back to explore some of the challenges of combating the seasonal flu during a pandemic. Through her work with infectious diseases, Dr. Carrico will give insights to how diseases function and ways to prevent or lessen their spread. Welcome, Dr. Ruth. We will let you speak in a minute. Before we start, I want to make sure that everyone type the county that you come from in the chat. It helps us to just show where we all are coming from and what's the spread of our information and reach. And also, if you're in a professional capacity, what county you are serving. So thank you for that. Before we now start, I'm going to ask Dr. Laura Morton to just give us an update of how things are going in our community in relation to infection and COVID-19. Thanks, Dr. Morton.
Hi, good morning. Thanks for having me again. It's good to see you. And Dr. Carrico, good to have you. Always good to see you. She probably could give this update, but I'll go ahead and give the update today. As of yesterday, Kentucky had 643 new cases yesterday, and it brings us to a total of 80,930 total COVID-19 cases in Kentucky. We've tested over almost 1.7 million tests in the state, which is pretty amazing considering where we were a few months ago. So it's been quite the journey. Our positivity rate remains under 5%. So in the state, we're 4.37%. In Louisville, in Jefferson County, we're I think 6.7%. And for those of us who work in the long-term care setting, we're so happy that we're under 10. As we are under 10, we are testing once weekly for the staff members in these long-term care facilities. So that has been a very integral part of the surveillance process for looking for COVID-19. Right now, there are 672 hospitalized people. There were 3 deaths reported yesterday for a total of 1,255 deaths from COVID-19 in Kentucky. The other thing I wanted to bring up is again, the importance of masking and wearing your mask, hand hygiene and social distancing. Also, the other thing is trying to minimize the number of exposures you have. So if you're going to go out and do a haircut, then maybe you don't do 2 or 3 other things that around about the same time. Again, I think we've seen an increase in numbers as people have more contacts, people have gone out more, and people have been, and then the children, people are going back to school, whether it's in the younger grades or if it's in college. And I go back to the nursing home setting, they're doing visitations, though they're still limiting them depending on the facility and if they've had positive cases. So that's something you have to talk to each facility about. But again, just remember, Ruth's going to talk more about the vaccination for the flu, but that's another important part moving forward. So thank you all, and thanks for having me, Anna.
Thank you, Dr. Morton. And now it's really my pleasure to introduce, I'm so sorry, my video went off. This is an interesting morning. So it's really my pleasure today to introduce Dr. Ruth Carrico. She is a professor and family nurse practitioner in the Division of Infectious Diseases and clinical director of the Global Health Center Vaccine and International Travel at the University of Louisville School of Medicine. Dr. Carrico is responsible for the clinical and research operations at the University of Louisville's Global Health Center. That includes the healthcare associated infection epidemiology and clinical research components, vaccine and international health and travel clinics, and the refugee health and immunization program. Her research has been funded by the CDC, HRSA, and DHS. Dr. Ruth, thank you so much for your willingness to spend time with us this morning, and the floor is yours.
Sure. Thanks. Thanks, and thank you, Dr. Morton. And I'm appreciative to have the chance to connect with everybody today, because as we've learned, COVID-19 is everybody's issue. And we all have a responsibility in not only addressing this, but I think even more importantly, trying to figure out how do we coexist. And that's really the point where we are now, that we have tried a number of approaches, and we've seen countries around the world try a number of approaches. So, for example, I'll use Argentina. I have a friend in Argentina that sends me an email every day. They have been in quarantine for more than 200 days in that country. That means, citizens all around are confined to their house, unable to go out at all. You can go out if you are an essential worker. Yet the rates of COVID-19 continue to be rampant in the country. So we know that complete isolation doesn't work, that when we have human beings that are used to socializing, and that's, we don't operate very well in quarantine or in isolation from each other. We also see a number of problems with shutdowns. So for example, we see the gap between children who have opportunities to be taught at home and those children who do not. And we see that educational gap widening, and then that creates the issues with all of the social and health disparities that we struggle with. So somehow we have to figure out how to live with this virus, and figure out then how we can continue to move forward as a society. Now, saying that means that healthcare workers have tremendous responsibilities. And when I say healthcare worker, I mean the entire gamut, anyone that has any involvement in promoting and protecting the health of those in our community. So it's not just frontline healthcare workers, it's all of the disciplines that are working together to address this. So, our challenge at this point is understanding how the disease is transmitted. And even that, we know we're right in the middle of the CDC scientific briefing that came out that mentioned airborne transmission. And so I want to kind of take the opportunity to just bring some grounding to that statement, because many of you may be struggling with that, to say, well, how are we going to deal with this in the time of influenza, if this is an airborne organism? CDC has not changed the position with respect to how this disease is transmitted. This is primarily a respiratory droplet organism that is transmitted when people project these respiratory particles. That may be during talking, humming, laughing, sneezing, singing, and the more force with that projection means that I can then promote or propel those infectious particles even further. So think about your 80-year-old resident in a long-term care facility. If they cough, and if Justin Magnuson coughs, he is probably going to be in better physical condition and able to project those respiratory particles further than our residents. So when we think of that, then we say, oh yeah, these particles may be in the air for some period of time and not just simply fall out within a 6-foot distance from the individual that is coughing. So I want to make sure that this new information from CDC, or this new statement, doesn't undermine the very points that Dr. Morton mentioned a few minutes ago, and that is the importance of this universal source control, or masking, by all healthcare personnel, and the use of some type of face covering for visitors or others that may come into the facility. That if I can maintain, and if I can keep my respiratory particles from being projected directly into your face, then that's how I can minimize transmission opportunities. We know the microorganism can live on surfaces, but to tell you the truth, it is inside your body, it is ferocious. Outside your body, not so much. Easy to kill with the routine types of disinfectants or germicides that we use in healthcare settings. So, and concern needs to be on preventing that movement, that projection of respiratory particles from me directly into your face, eyes, nose, mouth, so that you then are able to provide a place for that virus to attach and then begin its process of invasion and infection. So, knowing and understanding about how COVID-19, how this virus is transmitted, makes it easy for us to kind of translate this knowledge to influenza. So I want to stop here and kind of get some comments from those of you that are with us today. And I see Andrea has a comment that there's a lot of debate on social media amongst infectious diseases, whether we should refer to COVID transmission as aerosol or bring airborne. Yeah, and I think the term airborne has one context to us in healthcare, that we tend to use that category to say, here is a small particle that is able to stay afloat in the air and actually move with air current. And then the inoculum, or the amount of organism to cause infection, is so small that that places other people at risk when they are in part of that shared airspace. So they can be in another room, but yet the air moves from one room to the other. So we typically, and I'll use measles as the example. Measles is one of those where it's a very small particle. It stays afloat in the air, kind of resists all the drying that we see with other microorganisms. And it only takes a few to cause illness. So our exposure example for measles is, if you're in an shared airspace for 5 minutes with me and you are susceptible and I am the infected individual, we assume that infection has occurred. And we know that it takes a very few numbers of those viral particles to cause illness. The inoculum is very small. Therefore, we say one person with measles, or with that rubeola, measles, has the ability to infect 14 others. So that transmission, that kind of that rate of transmission, or that infectivity number, is very high. With influenza and with COVID-19, that infectivity number is much lower. It's about 2. It's about 1.5 for influenza, maybe 2.5 for COVID-19. So even though the particles can be involved in an aerosol, and an aerosol means that I have a lot of particles that I'm projecting at some point. So when I cough, or if an aerosol generating procedure is performed, like intubation, then all of those particles then bombard individuals that are close by. That's why we say, if you are involved in an aerosol situation, then we want you to wear a respirator, an N95 or an N99 respirator, because the way those pieces of respiratory protective equipment are manufactured, it's a bunch of layers that look like a bunch of different layers of Swiss cheese. None of the holes line up. And there's electrostatic pressure in between those layers. So it literally traps the microorganisms in those layers and keeps you from inhaling them. That's why respirators provide that higher level of protection than does a traditional medical mask. So our approach in healthcare is that if we are around individuals who are actively coughing, then we need to be concerned about, are those coughs so forceful that an aerosol can be produced? If so, then we wear an N95 respirator, which means that our patients that are ill with COVID-19, we are wearing an N95 respirator. Other individuals, other patients, we are wearing a traditional medical mask that really is a barrier between those particles and our face, eyes, nose, and mouth. So I hope that kind of helps to explain that a little bit, but you can see that there's still many gray areas, because how much aerosol is enough to make us sick? How much aerosol is enough to cause contact with me if I'm 7 feet or if I'm 8 feet away? So nothing is consistent. All patients are not consistent. All coughs are not consistent. All host Preventive risk or preventive factors are not consistent. So that's why we have to say our standard is the use of respiratory protective equipment like an N95 when we are caring for patients that are ill with COVID-19, patients or residents. And then all other times, we are embracing the notion of source control. So I'm trying to keep my particles to me. I want you to keep your particles to yourself. So by preventing then the opportunities for sharing, we minimize the risk of those who may be either asymptomatic and still infected and carrying the virus and able to transmit, are those that are pre-symptomatic, because we know with most viral illnesses, you are symptomatic, you are infectious about a day before you actually begin to develop symptoms. So we're trying to figure out all the ways that we can to contain these respiratory particles while allowing us to go on. So if I look at a comment from Mary Kay, she's saying, if I'm in Kroger or I'm taking a walk and a couple of people are speaking or laughing, should I take a route around where they had been walking? Probably not, because those particles generally are heavier than air and most of them fall out of the air. Now, if you walk directly into someone's cough, then that may be different. But I think then that idea of maintaining that spatial separation and just knowing that when you're out in the air, also remember we've got a lot of movement of air as the wind is blowing. Even a gentle breeze is enough to move these respiratory particles and dilute them. And then we still have some benefit of UV radiation from the sun, that although it's not enough to provide complete germicidal disinfection, it still is quite helpful in reducing then microorganisms that are, able to continue and survive. That's why being outside is one of the best approaches for preventing transmission. So, we have seen in healthcare people that will say, well, I know that masks and face covering can provide us with some level of protection. And especially it's better if everybody's wearing them, because then we have a decrease in anyone's ability to project those particles. Yet if we all sit down and go to lunch together and we all have our masks off, even though we're all eating, we are all still breathing. So really great prevention opportunities may be happening in the workplace, but that we undermine everything when we congregate in break rooms and sit and eat together. And we think that somehow all of these kind of rules of transmission are suspended while we're eating. In fact, they're not. And so part of our new ability to coexist is understanding what is the theory behind transmission, and then taking action to minimize our opportunity to be exposed by others as well as expose others. So I see Barbara has a question about how effective are masks really? It's interesting. We don't really know. There are a lot of research studies that are going on now looking at a variety of materials. Which is better? Is it better to have 2 layers of a cotton t-shirt? Or, we've seen people that will make material masks and then cut up the baggies that go in vacuum cleaner that are like their HEPA filters, and make a little pocket and stick that in. So, it's interesting that the entire world is focused on this one disease, and we're seeing all of this innovation and a lot of research that is going on, but I have to say not only good research, but really bad research as well. So it's hard to know now what to believe. And, I was telling somebody earlier that, if I don't know, if I'm trying to forecast or, make some kind of prediction, I oftentimes will consult my Ouija board, because I've found that is probably just as good as any other way of trying to determine, the truth. That, we have to be really good at reading research, and we have to be really good at trying to figure out, what makes sense and what doesn't. And then we have to have a good network of people that we can talk to say, there's something about this that is intriguing to me. I'm not sure if it makes sense from a science perspective. What do you think? So, you know, forums just like this one, where you can come together to say, I read something and it seems really good to me, but is it factual? And what's the science behind this, that we can begin to have these types of discussions, because we've never had this type of disease before. We've never had the level of collaboration and the immediacy of learning that we have now with COVID-19. So it makes, again, these kind of virtual exchanges even more important. So let's see. Is it okay? Anna, I'm just kind of going through some of these questions. Is that good? Okay, so I see Colby says, Swiss cheese model, stacking masks, social distancing, rapid testing, being outside, hand washing. You're right. All of these types of things, that if we can line them up, we're going to have to be really good at like screwing everything up to make those holes in the cheese line up. So, you know, none of them work. But I think you're right that if we are employing all of these types of interventions and doing them with some kind of thoughtful approach, that's how we coexist with this virus, because we have to, from an economic perspective, we have to get back to work. We have to allow our children to get back into some type of social environment for learning. You know, we have to help people then, you know, get beyond this level of fear, because we all know that, you know, many of us have pretty good coping mechanisms. Many others have very poor coping mechanisms. And so when we layer the social isolation on top of that, you know, we create issues that are going to be very difficult for us to untangle and address. But we know that this organism is here to stay. We know that it is not going to go away. We are going to have to find ways. This is why so much is being invested now in improving testing abilities, in improving our therapeutics. You know, what treatments do we have, and then so much approach on vaccination. So this is our new normal with this virus. How we address it is going to be the, you know, kind of what happens in the future. So I see Pam is asking about the air purifiers. You know, a lot of emphasis now is going into understanding airflow. And ventilation systems. Many of our long-term care facilities are older buildings, not all of them, but many are. Many will then have HVAC, or the heating and air conditioning and ventilation systems that were designed years ago. We may not have a good understanding about airflow in our buildings. We may have limits in terms of how much fresh air we can bring in, especially now as we look at the winter, when we're going to have to, you know, warm the air. So bringing in fresh air is going to be a burden on energy consumption, and that is cost that we will have to devote. So a lot of work now is going into figuring out, you know, what are the technologies. And if you're like me, every day I have someone that is calling me about a new product that is going to change the world. And we're really having to develop a methodology for how we evaluate this. Just because it's got a great brochure and it sounds wonderful doesn't mean that it works. So we're really spending a lot of time trying to develop some educational programs. But air purifiers, it may clean or disinfect or scrub the air, but the problem is occupied spaces continue to have people that are continuously breathing, continuously exhaling. So we are continuously having then microorganisms added to the air. So it depends upon where the air purification mechanisms are. So you can have dry hydrogen peroxide, or you can have some of the new needlepoint bipolar ionization. You can have UV lights installed in ventilation systems, but it all depends on where they're installed and where they are in relation to recirculated air that becomes really important. So there is no piece of equipment now that is going to provide you with sterile air all the time. And I think that, you know, we have to kind of understand how that works and how it works in our individual facility. But I can tell you the whole notion of indoor air quality is on everybody's radar right now. So I know we're trying to develop some training for long-term care facilities where we can help people understand these technologies, because I'm sure they are in your facilities now to sell you the latest and greatest. And you need to be knowledgeable, or with the facilities need to be knowledgeable about these devices and what they mean, what they can do and what they can't do. Somebody said, I have masks with different fabrics. Is it problematic to use a lightly used mask because it matches my outfit? No, use your mask however you want. I would, if you're wearing a cloth face covering. Remember, if you're wearing it for personal protective equipment, if you're a healthcare provider, you don't wear a cloth face covering while you're at work. You wear a mask or an N95 respirator. Remember, a mask is different from a respirator. If you are out in public and you're wearing a face covering, so like one of the few things I still do now that I try to do without fail is Pilates. I go to Pilates. When I'm in Pilates, I wear a face covering. I don't wear a medical mask. When I'm done with it, every day it's washed and I put it in a dryer, in a hot dryer, just to expose it to heat. Because again, remember, COVID is a very wimpy, just like influenza, very wimpy virus. You can kill them quite easily. And then that mask is yours. So on the inside, those are your particles you're projecting. On the outside, it may be something that somebody else has been projecting toward you. So I'm going to try to be careful, and I always know which side is my side. Which side is my side and which side is the outside. And I try to always keep, so I have like a little paper bag in my car. I drop my mask in. I try to put it in the same way. So like, here's the front of the bag, and I put the front of my mask in the front of the bag. So it always goes in that same way, and I'm pulling it in, pushing it in and pulling it out. That's just my way of keeping track of that. But, those of you that know me, I'm a little bit on the OCD side with infection control. But I found the way that I can coexist. I've kind of learned what I need and what makes me feel confident or comfortable. And I think all of us kind of have to find that comfort zone. Justin was asking about if we use a small common break area that's used one at a time, is cleaning the surfaces enough? I think, yeah, just so like what we do in my space, we just keep these little disinfectant wipes, individual wipes, and we just keep the surfaces wiped. It's everybody's responsibility that, after you leave a room, you clean it for the next person. Once you go in, if you're not so sure about whether or not it was disinfected, then you pull up a wipe and then you wipe the area. If you are having trouble identifying disinfectants, and we know that sourcing disinfectants now is really challenging, that some of the companies are unable to provide the items that we have come to use, maybe a lot of the pop-up wipes. Now many of the companies will provide you with information about how to make your own wipe. So you use their chemical germicide and you can pour it in these rolls of towels that you can purchase. Just remember, the germicide impacts and it interacts with the material of the paper towels. That's called the substrate. And so some of them are designed to work very well with some of the substrate. So, for example, if you have a paper towel that's manufactured and formaldehyde is in the manufacturing process, that may not work well with the germicide. So that's why we try to buy those products that are manufactured in combination already. But if you don't know, don't worry about it. I'm not particularly worried about it. I'm going to get a roll of paper towels and I'm going to put some germicide. I'm going to have a container and I'm going to pour the germicide in so I can have a wet paper towel. For this microorganism, it's good enough. And the FDA may say, well, you're not following all the FDA. I understand that. But for this organism, it is not a particularly problematic organism on environmental surfaces. I'm going to be perfectly fine with that. That's what the evidence is telling me. What do you recommend families do during the holidays? Families not get together, we figure out, and what's that middle of the road and what's winter going to be like? Well, this is the challenge for us because we know we see influenza every year It's a seasonal virus. We see it all the time, but at very low levels because it doesn't particularly like summertime. It doesn't like the high relative humidity. It just doesn't thrive in that type of environment. Once the environmental humidity starts to go down, that's what influenza loves. It loves and it proliferates very, very well. And then when we are inside, we're outside less, but we're inside congregating together, and it's a respiratory infection, respiratory virus, that's when we begin to see transmission. We know that we start to see transmission usually around when the weather when it's gotten very cold, consistently cold. So it's usually in late November and December. That's when we start to see our increases. And we see the most cases during the time of year when it's the coldest. So that's January and February. The problem is the vaccine really it's got a limited durability, meaning it doesn't last for the entire year. We think that typically our injectable flu vaccine lasts probably 24 weeks. That's when it is the most effective. So kind of think about timing. If I know that our disease is greatest during November, December, January, February, that's kind of a 16-week period of time. Don't be getting your vaccine in July or even August. And from my perspective, we vaccinate everybody in my division usually on Halloween, because then I know my vaccine takes about 2 weeks to give me full protection, whatever I'm going to be able to use, however long I'm going to be able to use that vaccine takes about 2 weeks to ramp up my immune response. Then I've got about another 20 or 24 weeks until my durability or my body's ability to recognize and produce antibodies effectively and quickly starts to diminish. So if you are vaccinated October, then your vaccine is likely to be in full effect all throughout the flu season. So that's kind of the reason to vaccinate all throughout the season. If you missed your vaccine in October, don't think, well, it's too late. I may as well give up now, or I haven't gotten sick, so this is going to be a good year for me. Please don't think that. It is important for us to be vaccinated with influenza this year, not because the vaccine is going to prevent COVID, but I want you to think about flu is not just a bad cold. It's not just a bad cold for you, and it's certainly not a bad cold for others that you may transmit it to, including the residents in your long-term care facility. Influenza infection causes an inflammatory response. That's why we're seeing a greater incidence of acute MI, a greater incidence of stroke and other cardiovascular events, a greater incidence of poor diabetes control, this metabolic impact. So flu is a crappy disease, just like not as bad as COVID, but it's still a bad disease. And once you are sick, if this is your baseline health, once you are sick with influenza, you're down a little bit, even if it just caused you to be sick for a week. If you were an older individual or somebody with comorbid conditions, then now your baseline during influenza or immediately after is down here. If you become ill with COVID after influenza, before you've had a chance to recover, your body is less able to take on that additional insult from COVID-19. So having a flu vaccine that may keep you from developing severe influenza disease. Remember, even if the flu vaccine doesn't prevent influenza, you are less likely to be hospitalized or die from flu if you've gotten a flu vaccine. So we know the benefit is tremendous. If you become sick with COVID-19 as part of that reduced kind of baseline, you're much more likely to experience the more catastrophic side effects of COVID-19 disease. And so why would we want to do this? Not only we don't want flu and we don't want to transmit it to others, but we especially do not want to run the risk of developing either co-infection, maybe flu and COVID at the same time, or COVID after I am trying to recover from influenza. So I think the bottom line is there is literally no reason to avoid vaccination from influenza this year. Absolutely none. If you've been somebody who said, I don't really need it in the past, please rethink that decision this year and seek influenza vaccination, and make sure that your residents are vaccinated as well. Again, and use the right type of vaccine. We have a number of vaccines now. It's like almost a precision vaccine in that you have vaccine that targets the immune system for those whose immune system may be kind of getting a little on the senile side, or retiring, that immunosenescence, that their immune system doesn't respond as well. We know we have different types of vaccine like high dose flu or the Securus vaccine, FluAd, that's an adjuvanted or an additional element in the vaccine to prompt your immune system. So, make sure that people are selecting the right type of vaccine. But getting back to your question about do we get together, I still want to get together with my family, but we're going to have to be smart about it. That may mean that everybody wears face covering during your Christmas celebration. Think about, people are going to be creative. I'm sure we're going to have all kinds of masks with a Rudolph the red-nosed reindeer nose or all kinds of stuff on there, just to, bring a little bit of the holiday festivities. But yeah, I think we need to be supportive of each other, and we're social beings. We just have to be smart about being social. Andrea is talking about natural cleaners. Remember, a natural cleaner, a green cleaner, cannot have a germicide. A germicide is a pesticide. So there is no such thing as a natural germicide. Even things like citric acid may bring some acidity to the environment, but we don't have evidence that it will actually provide the logarithmic reduction or the number of microorganisms killed in order to render that environment, kind of meet the hygienic environment considerations. Now, is it better than nothing? Absolutely. A detergent is better than nothing. In fact, we're even seeing that, I think, Pine Sol, that is not a germicide at all, is a pine scented cleaner, actually shows that if you use a microfiber cloth with a detergent cleaner, you will physically remove just the mechanical removal of these microorganisms. And all that is without a disinfectant. So if you have somebody that maybe has allergies at home to disinfectants, I would say use a microfiber cloth, because you will mechanically remove, just by elbow grease and the components of those microfiber cloths. You'll do a great job. It's not good enough for healthcare, but it'll probably be good enough at home. But remember, if you have microfiber cloths, you have to launder them separately. You can't throw them in with a cotton towel. All the fibers of microfiber will grab a hold of those cotton fibers and it will render them ineffective. So you have to, I never thought, when I was went to nursing school, I thought I just want to take care of patients. Now I have to know about textiles and engineering and all of that, and sometimes it's like too big for my mind to get around. But it's a reminder that in the 21st century we've got 21st century new knowledge. All right, Mary Kay asked about which flu vaccine you receive at a place like Kroger. I think that most of the retail settings are going to use the vaccine that is going to be priced the best for them to give in mass numbers. And there's nothing wrong with that. They're going to get the routine quadrivalent influenza vaccine. And that's what many people, that's perfectly appropriate for many people. If you're 65 years of age and older, they should be administering the either high dose or FluAd, one of the vaccines that are designed for individuals 65 years of age and older. But if you don't know, tell them, say, hey, I'm 65 or 67 or whatever, and I want you to give me what I got coming to me. So give me that high dose vaccine, and they should. If they don't have it, they should tell you that. But unfortunately, I don't know what the approach is in all of the pharmacies, if they will tell you that they don't have, or because CDC has said they're not preferential. The CDC doesn't direct, and the payers don't direct what type of vaccine to have. Unfortunately, sometimes that puts us on the consumer on the side of asking for what is needed. Is there a preference for injection versus nasal spray? No, there is no preference, but we are learning. And, it's interesting because the nasal spray vaccine, the initial data that we had when it first released showed that for kids, it was truly the best vaccine. And actually it was much more durable, meaning it lasted much longer than the injectable. And it's a great vaccine because it only replicates in the nose. It can't make you systemically ill. But it promotes an excellent response. Then a couple of years ago, when the company moved it from trivalent to quadrivalent, the recipe, it inactivated the vaccine. And so for 1 year, the vaccine just simply didn't work. So they pulled it from the market, went through all of the processes to try to figure out what happened with the combinations. They provided additional data back to the FDA and the CDC, and now it is back on the market. I think it's an excellent vaccine. I think it can only be used in children and adults, maybe year 2 to 49. I think I'd have to refresh, but I think that's the age range. But I think for children, it's great because, you have children that may be afraid of a needle, or the parents may say, I can do it for their routine immunization, but it's just too much for me to take them in. And it's just, too traumatic. We're just going to try to avoid flu. Well, give them nasal spray then. It's much easier on everybody. For adults who may be afraid of needles themselves, it's a great vaccine. It's certainly better than going without a flu vaccine. Now, once you're over the age of 49, it's not that it quits working at 49. It's just that no studies have been done in adults over that age. Let me see. Have I gotten most of the questions? Because, I was raised a Southern Baptist, and I'm sort of feeling the Spirit move me. And so I'll just ramble on and give a sermon, for the entire time that I have with you. So that may not be the best. That may not be the best thing. So and if you need to bring out the hook and say, enough's enough. But I think one of the questions that I get asked a lot are, what's the difference? How do I know, flu or COVID? You really don't. They both have, flu has a maybe 1 to 2 day incubation period. COVID has a 2 to 12 day incubation period. But if you have the symptoms, many of the symptoms are, very similar: fever, chills, headache, body aches. We tend to see that new loss of taste or smell more frequently with COVID, but I have had patients in the past with influenza who complained about the same thing. I just never picked up on it. But I'm like, oh yeah, I remember somebody telling me that before. So it's not exclusively for COVID, but because it happens more frequently, if somebody tells me that, then I'm probably going to lean more on the side of COVID. But, both of them are nasal swab testing. And even if you have had flu vaccine, I would still consider influenza on the differential. And so as a provider, I'm going to be using more liberal, I think, with my antiviral prescriptions this year than I've done in the past. Because if you've got a disease and I can give you, Xofluza, that's 1 pill, 1 dose, 2 pills, 1 dose for adults. And that works really quickly. And if I give you a dose of Xofluza and you start to feel better, then I'll know it was probably flu and not COVID. If it's COVID and not flu, the Xofluza won't help you, but it won't hurt you either. So I can see already. So, in my office, I've already got doses where I'm going to give them to people and then send them a prescription and say, bring it back to me and refill my stock, just to make sure then that we can get the medicine in them quickly.
Okay, there's another question there, Ruth, on hand sanitizer, hand lotions that can be used as both a moisturizer and a disinfectant.
Mm-hmm. Yeah. So I think we're seeing products that are introduced like benzalkonium chloride and others that are non-alcohol based that are in combination with some lotions. I would say the only data we have is on the alcohol hand rubs, and those then have a really rapid kill effect on your hands. All of the formulations, those made by the distilleries as well as those that are manufactured, all have some type of emollient, glycerol or something in it that provides protection for the skin of our hands. Sometimes the lotions will have they're made with lanolin, and that's sugar. And so we see lots of outbreaks associated with hand lotions that people will bring in because it smells good. It also harbors a lot of microorganisms. So we try to say, if you want a hand lotion, let's try to get something that is kind of that pharmaceutical grade that we can order, that we know is compatible with our hand soaps, as well as alcohol-based hand rubs, because hand soaps now, they change the pH of your skin, and if you bring a lotion in that has a different pH, it kind of negates then any persistent effect of the soaps that we may have used. So there really is some science behind the selection of a lot of these hand hygiene products, but the non-alcohol based products, we don't really have good data. And in fact, some of them are quite problematic, that they create lots of skin issues, and they will be rendered ineffective by any sort of contact with soap. So I would always recommend sticking with the alcohol based, at least where we have the data. How concerned I am for this flu season? I'm very concerned. The Southern Hemisphere didn't see a terrible flu season. Probably, I agree with you, Kay, or I think it's Andrea. I think you're right that as people have been wearing masks for COVID, that is decreasing our transmission opportunities for influenza. So we very well may see our numbers decreased. I hope so. But my concern is that, I always look at my patient is my N of one. What is it that I need to do to protect my patient, whoever I am responsible for? And I think I am going to be providing care for them. Therefore, I need to make sure I'm doing what I need to do so I don't cause them harm. And I know if I develop influenza, either because I was not vaccinated, or maybe I develop it despite vaccination, but I decide to come to work sick, or not wear a mask, then I may hurt my patient. And it's my professional responsibility not to do that. It's also my responsibility as a nurse to use the power that I have with the public to talk about, preventive measures. And, although I'll say as a nurse, it's not only nursing responsibility, but I bring the point that the public listens to their healthcare providers. They listen to what we say. If we talk about prevention, then we have the ability to impact their decision-making. Just like they hear our words, they hear our silence just as loudly. So if we don't talk about this, then they assume it's no big deal. So if we are not talking about influenza vaccination, or we are not talking about, universal source control, then they think, oh, I heard that from somebody else. But if it were important, I'd have heard it from my nurse, my social worker, my nursing assistant, my physician, my others. So think of the power that you have right now, and use that power to help us coexist with this pandemic through the use of the preventive measures that we know work. Again, if we don't implement anything, it's like people say, well, I don't know the flu shot works, but I'll say, well, but I can guarantee you, if you don't get a shot, you'll have zero impact. You'll have no effect. Even if the flu shot is 10%, 20% effective, and it's always at least 10 to 20% effective, that translates to tremendous numbers of individuals who won't get sick or hospitalized and die. So to me, that's easy math, right? If I can do something to prevent the death of somebody in my family or my patient, why would I not do it? I don't know. Yep, I think people have
There's another question from Justin.
Yep, I saw that. With increased hand washing rates, have we seen decreased rates of other communicable diseases or infections? You know, that's interesting. I would have expected that we see decreases in healthcare associated infections, but I'm seeing a lot of conflicting data. So I'm not really sure yet if we're seeing an impact, or, you know, if are we just either seeing better or worse surveillance? I don't know. But I would think that if we are promoting hand hygiene, that we should be seeing a reduction. And then I think the question about people who unfortunately distrust vaccines, and I think that's true, and that's so sad that that there is mistrust, because if you look at, I mean, vaccination, the impact of vaccines is second only to clean water in terms of its public health effect. So no other public health intervention besides providing clean water has saved more lives than vaccination. You always have to look at what is the risk of the disease and what is the benefit then of the vaccine. And somehow we have to have those discussions with people to say, I've seen, you know, these diseases. I know what it can do. I know what vaccination can do. And I know that we provide tremendous surveillance for vaccines, both all throughout the clinical trials, as well as what we call phase 4. That's when all vaccines are available. We have 3 major processes in the United States that constantly looks at medical records and the administrative reporting of diseases, looking for relationships between disease and vaccines. We also have the vaccine adverse event reporting system that patients can say, hey, I experienced this side effect. I want to put it in the registry so we can begin to monitor. So we do tremendous surveillance for side effects post-vaccine. And through all of that, we still continue to see, you know, mountains of research and data that shows us the effectiveness, the importance, and the safety of vaccines across the board. I guess no intervention is completely without risk. And people will ask me now, Ruth, what are you going to do for the COVID vaccine? Oh my gosh, they're coming to market so quickly. Are you afraid? I'm like, I am more afraid of the disease than I am of the vaccine. And so if there's a line that's forming for the vaccine, get behind me. I'm going to be there. So if I am able to get the COVID vaccine, whichever one is approved, once it passes the FDA requirements and is released, even under emergency use authorization, I'm going to be in line, because I do not want the disease. I'm seeing patients with long-term effects from this virus that I do not want. So I'm looking at risk of the disease is too high for me. I'm going for the vaccine.
Wow, that was a lot of really good information, Ruth. Thank you so much. There's another question. How likely is it, though, that people will willingly be vaccinated, from Barbara?
Yeah, you know, I don't know. That remains to be seen. That I think it's like, I don't know if you are familiar with the Gartner, the hype cycle, and that's like a graph that says, okay, whenever we have anything new, we always have early adopters, you know, that are right on board, and then we have, you know, then we have others that they're going to wait and watch, and then we have the laggards. They're going to wait to the very end or never at all. I think that happens with, you know, that happens with everything, that we will have those at the very beginning that are like, let me on board, that are going to be, you know, completely into the vaccine. So like from my perspective, I'm reading everything I can about the vaccine so that I understand how the development is occurring, at least to the level. I'm not an immunologist or a virologist, so, you know, a lot of it is over my head, but I can figure out some, and I'll ask my colleagues, help me understand this. So I'm reading everything I can about the vaccine. So I know right now that the vaccines that are in phase 3 not only produce antibodies, they also have the side effect profile that is in line with other vaccines, meaning you get a sore arm, you may have fever, body aches, chills, nausea, diarrhea. That's part of your immune response. That's not an illness. That's our body producing antibodies. That's how we are impacted. So we're going to have a brand new process for providing me with a signal to produce antibodies, and my body's going to respond to that. So I'm reading about that, and I'm reading about immunogenicity, meaning what's the antibodies. I'm reading about reactogenicity, meaning what's the reaction or the adverse effects. And then now I'm looking to see what are we seeing with respect to safety signals. Are we seeing anything additional as the vaccine trials move from 10 people to a couple of hundred people? Now it's in tens of thousands of people all over the world. Remember, the vaccine companies are trying and introducing vaccine for phase 3 in places where there is a lot of disease, because you've got to be able to see, if I give some of the people the vaccine and some placebo, I've got to see, is there more disease in the placebo group? Therefore, I've got to have disease in the community that will cause people to be sick. So we've got to trial these in the right types of environments. And right now, the 3 vaccines that are kind of the front runners in the United States are all proving to be effective. Now it's going to be who meets the FDA requirements for the study, who begins to provide that vaccine first, and then how are we going to get it into the arms? Because right now they're all intramuscular injections. It's either 1 or maybe 2 doses, maybe a second dose 3 weeks after the first. And the phase 1 targets for vaccination are going to be essential healthcare workers. So that means we're going to be the ones accepting vaccine, and we're going to be the ones then that are demonstrating to the public about how the vaccines work. So we've got a lot of responsibility on us. Again, I bring back to it is our responsibility to help this move forward. And I see Barbara mentioned that J&J stopped anytime there is a new adverse event identified, the study will stop. That's part of the process. There is a pause, and what they do is they look to see, is the illness in the individual related to the vaccine, or is it like a temporal? It happened, I got a vaccine and I got sick. Well, true, but are they related? So this is what that pause happens. And this is a good thing to me, to see this pause, because that shows that the vaccine companies are doing what they have promised to do throughout these studies. And that is, if I see any issue, we're going to stop. Now, this is a vectored vaccine, meaning this is the message is attached to an adenovirus or a cold virus. So the J&J vaccine is a live vaccine. It's not giving you COVID, but it's using then a virus to introduce into your system so it can get past your body's initial defense and recognize it as foreign and start that antibody response. So it's a very unique approach. So we'll see what happens, but I look forward to more discussion. And these were great questions. I thank you all very much. This is fabulous, fabulous.
So sorry. What a wonderful discussion this was. And we are almost out of time. I think there's one question here that I want to ask quickly, and that's the one related to the cultural diversity in participants in the trials. Do you have any thoughts on that?
Yeah, so this has been a big issue, that we do not have good representation across all populations. And this is a challenge that we're gonna have. I've spoken with a couple of groups about how we can engage more of the African American population in the clinical trials. Well, we've got a lot of trust issues. You just go back to Tuskegee, and historically, this has been we violated trust. How are we going to get trust back? So this is a huge problem, because what are we going to have when this vaccine is released? We're almost in a catch-22, because we need to have the African American healthcare population to be willing to be part of either the clinical trials or the early release of vaccine in order to demonstrate effectiveness. So if we don't engage the population, then we're not providing then vaccination in groups where the health disparities are significant, as are the morbidity and mortality rates significant. So this disproportionate amount of disease that is occurring and the severity of disease is troubling. But if we can't get groups to accept vaccination, I don't know how we're going to get ahead in this. So, we're going to have to get groups together to figure out, the right approach. But, in the back of my mind, this is yet something else that will be politicized when it's not this doesn't belong to the Democrats or to the Republicans. This belongs to us. And so, take the politics out of it and get into the community level. And so I think, again, it's through discussion forums like this that we can begin to say, how do we address this? How do we approach this? Mm-hmm. So, because remember, this is our community. This doesn't belong to Governor Beshear. This belongs to us. So we have to take the responsibility of helping our community. And that means we've got to work together. So one of our big challenges, I think.
Thank you, Ruth. This was an amazing discussion. Thank you so much. And thank you for jumping in at the last minute and saving us, and then really have this wonderful discussion. It is 11 o'clock, and I want to say thank you for everyone who joined. In 2 weeks, we're going to talk about COVID and voting. So we'll see you in 2 weeks. Thank you so much, and bye.